Next presentation is on imaging, anatomy and common pathology of larynx and hypopharynx by Dr. Diva Shah. She is Senior Consultant Radiologist at HCG Cancer Center, Ahmedabad.
A very good morning to all of you. At the outset, I am very much thankful to all organizers, respected Kaustubh Patel sir, Rushan sir, for giving me this opportunity. And Dr. Nitin has made the job very easy. And I think all of us now very much acquainted with the radio anatomy and cross-sectional imaging in larynx and hypopharynx. So to begin with, radiologist plays a very integral role in evaluation of laryngeal and hypopharyngeal pathology for the evaluation of the disease, local extent, staging of the cancers, and post-treatment surveillance. So in this next 20 minutes, we will be overview the radiological anatomy of the larynx and hypopharynx, various imaging modalities. We'll review the common pathology and then to summarize. So larynx anatomy has already been covered. So this is the sagittal CT section of the where we can see the larynx and the hypopharynx. So it starts at the level of hyoid bone up to the cricoid cartilage, and it is a cartilaginous framework. So this is the CT scan where axial post-contrast images. We will see these are the thin sections. We will see the anatomy of the larynx and the hypopharynx. We are going cranial to caudal, and here we can see this is the level of the oropharynx, and then comes the median glossoepiglottic fold here. By the sides of the fold we can see the vallecula, and here this is the free part of the epiglottis. As we move down, we can see the pre-epiglottic fat space, which is seen well at the level of hyoid bone. So this forms the part of the supraglottis. As we move down, here we can see the paraglottic fat, and this is the level of the thyroid lamina here. The thyroid lamina has a it is partially ossified, which we can see here, and then if we go cranially, we can see the neurovascular bundle and the level of the thyroid membrane. As we move down here, we can see the level of the arytenoid cartilage, and further move down, this is the level of the glottis, that is we can see here the bilateral true vocal cord, and posteriorly we can see the level of the postcricoid region here. This is the level of the anterior commissure, which is a very important landmark for evaluation of the laryngeal malignancies. As we move further down, this is the level of the subglottis. If we see the landmark demonstration here, even the airway also looks different at the level of supraglottis, glottis and the subglottis. Here it is oval in shape. At the level of larynx, the airway looks triangular in shape, and superiorly it is quadrangular in the shape. And as we move further down, we can see the level of the subglottis ends, and here posteriorly we can see the beginning of the cervical esophagus. Again, this is the thin multi-reformations coronal image sections. Here we can see a very important landmark, that is the lateral laryngeal ventricular complex. Sorry. So here we can see the division of sorry, I'm not. Sorry. So the laryngeal ventricle, which divides here the larynx into the three different subsets. So anything which is cranial to the laryngeal ventricle up to the free surface of the epiglottis, that forms the supraglottis. So this is the pre-epiglottic and this is the paraglottic fat. The part of the larynx which is 1 centimeter caudal to the laryngeal ventricle, that forms the glottis, and beneath it up to the lower border of the cricoid, that forms the subglottis. So these are the coronal sections. Coming to the hypopharynx anatomy, which consists of the three major subsets, that are the pyriform fossa, which lies lateral to the folds cord. It extends from the pharyngoepiglottic fold, and then this pyriform fossa continues with the postcricoid region. It begins at the level of the arytenoid up to the caudal border of the cricoid cartilage. So the basically both the subsets, the malignancies originates from the one region, can spread into the other very often. But however, the treatment strategies and the prognostications varies for both the malignancies. Next, coming to the imaging modalities. So as we know that MDCT is the gold standard of the investigations in evaluation of the laryngeal and hypopharyngeal malignancy. However, MRI helps. It is complementary to CT in a specific cases, particularly in a doubtful erosions of the laryngeal cartilages, assessment of the pre and paraglottic space whenever we are dealing with the evaluation of the deeper space extension, submucosal spread of hypopharyngeal cancers, which can be well evaluated on MRI due to the high and very good contrast and soft tissue resolution. PET-CT has a role in imaging of the already treated cases in routine surveillance to differentiate residual disease burden versus post-treatment changes, and MDCT is the only investigation for primary evaluation of the disease of the laryngeal and hypopharyngeal pathology. Now, evaluation of the laryngeal cartilage, it becomes very crucial and most important for the decision making of the treatment of the cancers. On CT scan, the ossification, as we know that it varies from age. So sometimes it is difficult to differentiate whether there is a erosion is present for the bulky disease or not. But presence of the erosion can upstage the disease from T3, T1 to mucosally endoscopically looking mucosal lesion, and when there is a deeper extension is more and erosion is present on the imaging modality, it can upstage the disease. So this is how the on CT scan the unossified cartilage looks on your right, and the ossified cartilage will look on a cross-sectional imaging like this. CT imaging of the cartilage, how we can know that there is a, so there are the few terminology which is important, that includes if there is a disease which causes the erosion of the inner lamina of the cartilage, this is a positive finding and it is a specific for the thyroid cartilage involvement. If there is a lysis means here there is an involvement of the inner and outer lamina plus presence of the disease which is involving the entire medulla of the thyroid cartilage. So that becomes your frank erosion. It is very specific. And either if there is a presence of the lysis along with the extramural extension, that becomes a specific for the extralaryngeal extension. So all the sclerosis is often seen and it is sensitive on CT scan, but it is not specific. And if there is a lot of bulky disease which is involving the larynx or a hypopharynx, but when you can see very thin preserved hypointense line here, so that means although the tumor is bulky, but the cartilage is preserved. Now, in such cases, MRI helps to evaluate whether there is an invasion of the cartilage or not. So we have to compare the T2 weighted images with post-contrast T1 weighted fat saturated images. So here is an example of the bulky disease which is involving the supraglottis, and here we can see that there is a signal which is seen along the left lamina, and if the contrast enhancement is same as the tumor on post-contrast T2 weighted post-contrast fat saturated images, that means it is positive for the cartilaginous invasion. While what is peritumoral inflammation? If the cartilage shows hypersignal intensity, which is more prominent signal than the tumoral signal, and the enhancement is also prominent than the rest of the laryngeal tumor, that gives that is a peritumoral inflammation. So in such cases, bulky disease, when the cartilage is not ossified or when the disease is not showing the frank erosion or lysis of the lamina, in such cases MRI is helpful. Coming to the common pathology which is involving the larynx and hypopharynx. So we know that squamous cell carcinoma is the most common malignancy. There are other malignancy which affects the larynx and the hypopharynx also. And there are other non-neoplastic pathology that also we encounters in our routine practices. So this was a 50-year patient, male patient, came with the dysphagia, and the scopy shows ulceroproliferative lesion which is involving the epiglottis here. Clinically it was T2 lesion, and patient subjected to the CT scan. Here we can see the heterogeneously enhancing growth which is involving the free, and it is also involving the pre-epiglottic fat space also, and in other consequent sections, which also shows there is an erosion of the thyroid lamina, and along with that there is an extralaryngeal extension here. So this is how the CT helps to upstage the disease. It can change the staging of the disease. So for supraglottic squamous cell carcinoma, important things to remember that we have to see the pre-epiglottic fat space involvement and what is the inferior age of the tumor. So if there is an extension, there is a transglottic extension, impaired, So if there is an impaired vocal cord mobility, if there is a presence of a cartilage involvement or involvement of the apex of the piriform sinus, which is very common in the supraglottic malignancy, or involvement of the postcricoid region, or if there is a cranial extension of the tumor, which is in the base of the tongue, more than 2 cm posterior to the circumvallate papillae. So all these are the contraindication for the supraglottic laryngectomy. Early glottic cancers, the role of the radiologist is limited. Majority of the cancers are well seen on scopy. The role of the radiology is to see the laryngeal cartilage, the deeper space extension, and sometimes we may miss this early laryngeal cancers on CT scan, even with the next newer generations of the CT scan, where we take the CT slices of 0.6 millimeter. But we can see some mucosal irregularity or plaque-like enhancement, which is seen here. Subglottic cancers have the late presentation, the invasion of the cricoid cartilage adjacent trachea and cervical esophagus with extralaryngeal spread, which is common. So here is an example of the subglottic cancer, and it is very important for us to give the information to the clinicians that what is the length of the trachea being involved. I know this is the very common question of the Kaustubh sir and the entire head and neck team. Tell me the length of the trachea, how much it is involved. So we have to count the tracheal cartilage. We have to see the abutment or whether it is infiltration. So these are the very important points to remember whenever we are seeing the subglottic cancers. The nodal spread is common in case of subglottic cancers, and so level 6 nodes and the prevascular group of nodes should be looked very carefully. This was a 45-year female with a growth in the left piriform fossa. Now the common questions which we encountered as a radiologist, whether the disease is primarily hypopharyngeal malignancy or it is a laryngeal malignancy. So here we as a radiologist, we see the bulk of the disease primarily seen along with the endoscopic and clinical finding. So here this is a growth which is primarily involving the piriform fossa, the apex, and there is an extension into paraglottic space. There is also exolaryngeal extension here we can see, which is common in case of piriform fossa malignancy along the inferior constrictor muscle. And this is a companion case of the laryngeal malignancy, where the bulk of the lesion which is involving the false chord and the true chord, there is an extension here along the anterior commissure, and this is a common spread along the exolaryngeal, along the cricothyroid membrane here. There is also erosion of the superior and inferior. This is the erosion which is well seen here. This is how we can evaluate and stage the laryngeal and hypopharyngeal malignancy. So as we discussed the laryngeal, in case of laryngeal squamous cell carcinoma, the transglottic extent, what is the enteroposterior, whether the disease is limited to the hemilarynx or it is crossing the midline, presence and absence of cartilage invasion, exolaryngeal spread, and hypopharyngeal involvement. These are the checkpoints for us to remember whenever we are seeing the laryngeal malignancies. Pathways of extralaryngeal spreads not always just limited to the cartilage, but it is commonly seen at the level of thyroid membrane and also at the level of cricothyroid membrane, which is also important to report. And we have to see the window settings to see this small exolaryngeal extension, not through the lamina of the cartilages, but along the membrane, where the spread in the nodal disease becomes common. This was an interesting case of a 62-year male presented with pain and difficulty in breathing. On scopy, there was a mucosa was smooth, no ulceration was seen, and this is the MRI T1. This is a T2 weighted, fat saturated, T1 weighted, and coronal images. We can see the irregularly marginated hyperintense lesion, which is involving the posterior aspect of the subglottis, involving the cricoid cartilage. The differentials were given in those adenoid cystic carcinoma or chondrosarcoma. And this is the PET-CT patient was subjected for the PET-CT, and it was not FDGA with neoplasm. And the final histopathology was low-grade chondrosarcoma, which affects the thyroid or cricoid cartilage. This was again a large lytic and a sclerotic osteosarcoma, chondrosarcoma, which is involving the thyroid lamina. This is a 32-year male presented with occasional breathlessness, sharp shooting pain while swallowing, and patient was subjected to a CT scan. There was a submucosal bulge on scopy, and we can see that there is a very isodense lesion which is involving the left lateral wall of the oropharynx. There is no calcification here, no significant enhancement. It is showing the bulge into the oropharyngeal airway, and patient was subjected to MRI further for evaluation of the pathology. And here we can see the elongated hyperintense lesion which is involving the part of the oropharynx and extension along the hypopharynx here, and it has septal within. And we did the contrast. It shows the gradual enhancement, and this was labeled as lymphohemangioma, and patient underwent the sclerotherapy. And these are the post-sclerotherapy images where there is a significant reduction on the size and extent of the lesion. This is another case of the submucosal lesion, which is again hypodense on CT scan involving the false chord and paraglottic fat, the MRI of the same patient. And here there is a heterogeneous enhancement of the lesion, and the final histopathology was schwannoma of the false chord. Apart from the malignant and neoplastic lesions, there are other pathology that affects the larynx also. And this patient was came with a dysphagia, post-corrosive injury. I've taken this image from one of my friend, Dr. Shikha. And here we can see the virtual coronal and the CT endoscopic images. There is a significant stenosis at the level of subglottis. And the important things which we need to mention when we are seeing the stricture of the glottis or subglottis: what is the length of the affected segment, its diameter of the normal trachea, and the distance mainly from the upper end of the affected segment to the vocal cord and caudally up to the carina. So this information are very important to give to the clinician whenever we are seeing the strictures involving the subglottis or the glottic region. This was a patient treated for the laryngeal malignancy with radiation. And here we can see patient came in emergency with the stridor. We can see that there is a significant edema of the supraglottis and glottis. There is a lysis, and we can see that multiple air pockets seen along the cartilage, the thyroid cartilage, as well as along the cricoid cartilage. So we can see that this is a classical of the radiation necrosis. We are often seeing the patients with hoarseness of voice, and these are the classical signs for the vocal cord palsy. Here we can see that there is a enlargement of left piriform fossa. There is a medial displacement of the left A fold. There is also thinning of the left vocal cord muscle, and this is vocal cord paralysis. So whenever we see the patients with vocal cord paralysis, it is important to cover the CT scan or MRI from skull base to the AP window up to the aortic arch, because of the pathology we can see at any point of the thing. And this patient, it was a rare disease, which is the pseudoaneurysm of the arch of the aorta. Here we can see, and it was compressing the recurrent laryngeal now. So this is nothing but the very rare Ottner syndrome, which is causing the left vocal cord palsy. This was the last case to show you. A patient treated for the laryngeal malignancy in October 2022, again presented with hoarseness of voice, and on scopy it was mucosal irregularity in left true vocal cord. Now this is the FDG avid, very low grade FDG avid thickening, which is seen involving the left vocal cord intercommissure extending up to the interior aspect of the right true vocal cord. Apart from it, there are FDG avid nodes. So here this we have reported as this is a suspicious lesion, recurrent lesion, and these are it is more, and although not in the drainage area, and these are the tubercular node, which is a common scenario which we see whenever we are doing the restaging of the already known cancer, that we see multiple avid nodes and they are granulomatous in nature. So all avid on PET may not be necessary malignancy. So this is the important clue for us to differentiate. So finally, to conclude, knowledge of the cross-sectional anatomy is very essential. Most tumors are mucosal, that is squamous cell carcinoma. Think of other tumors when they are submucosal in origin. MDCT is the first choice for evaluation of the laryngeal and hypopharyngeal tumors. And it is very important that it helps in locating the tumor, submucosal and deeper extent of the lesion. PET-CT has a role in treating the laryngeal and hypopharyngeal cancers to differentiate mainly the post-treatment changes versus recurrence. MRI is recommended for non-ossified cartilage in evaluation of the bulky laryngeal and hypopharyngeal lesions. It also helps in evaluation of the submucosal spread of the hypopharyngeal lesions. And I have not included the ultrasound, but definitely ultrasound is a part when we are dealing with the evaluation of the neck nodes. And it also helps in a patients when there is a large exolaryngeal lesion and when the scopy may not be feasible. In such cases, ultrasound guided biopsy definitely helps in evaluation of the disease further. Thank you so much, and sorry for shooting the 2 minutes time. Thank you.